Hello and welcome to this video on malignant hyperthermia. This video is a part of our series on CNS pharmacology, so I suggest you check that out. This video will cover and start with the case of malignant hyperthermia, then move on to the concept of thermoregulation and how that relates to malignant hyperthermia, excitation-contraction coupling, the pathophysiology of malignant hyperthermia, clinical manifestations, and then finally the treatment. So let's start before any hesitation. Let's starting with the case. A 42-year-old male is undergoing a laparoscopic cholecystectomy for multiple echogenicities. What are echogenicities? They're just stuff that reflects the sound waves used in ultrasounds differently than the normal, let's say, the gut wall. So multiple echogenicities identified in the gallbladder along with a thickened gallbladder wall. What is a thickened gallbladder wall? It's one of the hallmarks of acute cholecystitis, shown by that arrowhead, and the arrows in this case show the echogenicities or gallstones. Anesthesia is induced. The surgeons notice increased difficulty in maneuvering the laparoscope due to severe abdominal rigidity. The anesthesia resident notes a steady increase in heart rate. Things are getting a bit shady. What is happening? I can't move my laparoscope. There's an increase in the heart rate, as the anesthesiologist is saying. What is up, surgeon? Further physical examination shows diffuse muscle rigidity. What is this presentation? This is a classic presentation of malignant hyperthermia in the OR. Malignant hyperthermia. Malignant, the word literally means born to be bad. If you have been in the wards, if you have been in the OR, if you have been in a hospital, anywhere near a hospital, when you hear the words malignant, your eyes open up. Something is really wrong. This is born to be bad. Hyperthermia, increased body temperature greater than 37.5 degrees centigrade or 101.3 degrees centigrade. You need to learn this word. There's no other way around it, but I'll make it a bit more easy when we study the concept of thermoregulation. So increase in body temperature greater than 37.5 degrees centigrade or 101.3 degree Fahrenheit. Hyper means greater, hypo means less. That's why when you have diabetes you have hyperglycemia, meaning the sugar levels are high, and if you have hypoglycemia, that means the sugar levels are low. So hyperthermia means, hyper means greater, thermia means temperature, greater temperature than 37.5 degrees centigrade or 101.3 Fahrenheit. Yeah, so the concept of thermoregulation. So there's a sort of a balance. So if you've seen any other of my videos, you'll know that I love making a balance between things. So there's a normal body temperature, which is what we talked about, 36.5 degrees centigrade to 37.5 degrees centigrade. There are heat loss mechanisms that function to decrease the heat of your body, and then there are heat gain mechanisms, and this whole balance is known as your homeostasis, because you're supposed to maintain a body temperature. Enzymes, your body mechanisms work at particular temperature, and if you increase those temperature or decrease those temperatures, things will not work. Yes, so let's look at thermoregulation in a bit more detail. So the normal body temperature, as we said, is from 36.5 degrees centigrade to 37.5 degrees centigrade. Temperatures greater than that classify into hyperthermia. This temperature is detected by your central and peripheral thermoreceptors. Central means present in your brain, peripheral means present in the rest of your body. So central and peripheral thermoreceptors detect this temperature. If the temperature is getting high, that means something is up. That's basically your brain saying, bro, you need to cool down. That's basically your brain saying to your body. So you have the activation of heat loss mechanisms. That sounds cool, but what are these heat loss mechanisms? Peripheral vasodilation. What is peripheral vasodilation? As I said, central means your brain, peripheral means anything other your brain, which means your arms, your legs, and the rest of your body, basically most of it. So peripheral vasodilation, the blood vessels in your skin, your arms and your legs, they vasodilate to increase the blood flow to your skin. What does that do? It causes heat loss. That's why when someone exercises and come back, they're all red and their body is hot. That means that's basically your body trying to lose the excess heat. How it does that is through peripheral vasodilation. Then you have splanchnic vasoconstriction. That sounds like a very, very difficult word. Let's break it out. Splanchnic means anything relating to your internal organs or viscera. Internal organs, especially those of the gut. So for example, you just come back from the exercise, you're just exercising and your body is rising in temperature, but your gut is having a very nice day. It's like, okay, let's digest the burger that he had. But hypothalamus goes like, bro, you can't be digesting burgers right now. This guy has his temperatures rising. You can't be digesting burgers and fries right now. I'm taking the blood from you and I'm giving it to the skin. So that's exactly what happens. Splanchnic means organs and the viscera, and the blood vessels present in these organs, they vasoconstrict. So burger digestion will happen later. Right now you need to lose heat, and for that it gives all of that blood to your skin, and through your skin you lose that heat, you lose that temperature. Diaphoresis. What is diaphoresis? Diaphoresis means loss of temperature from your body through sweating or through water. Excessive sweating is diaphoresis. This is exactly when you're feeling hot, you say, I'm going to take a shower. So this is your body's natural way of taking a shower. Diaphoresis. What if the central and the peripheral thermoreceptors detect a low temperature? This causes the activation of heat gain mechanisms. Again, this sounds very cool. How does your body gain heat? How does it know when to gain heat? It knows when to gain heat by those central and peripheral thermoreceptors. They're detecting that body temperature is getting low. You need to gain heat. What are we going to do? We're going to do exactly the opposite, or somehow similarly the opposite of what we did. We do peripheral vasoconstriction. So increase blood flow to your skin. What it does is it causes the heat loss. So you want to preserve that heat loss. You decrease the blood flow to your peripheral stuff like your hands and your feet. That's exactly why when you go out in the cold, your hands and feet, they get very cold really fast. This is exactly what happens. You decrease that blood flow to limit that heat loss through the skin. Shivering. How does shivering help? Increase movement, increase muscle contraction. When you're standing out in the cold and you're going like, you're basically contracting your muscles. You're causing your body to do work, to use ATP. And whenever you do work, you use ATP, you generate heat. This is exactly why you do this. You generate friction, you use ATP, you convert one form of energy, which is chemical energy, in the sort of ATP into thermal energy or heat. This is exactly what your body does on its own. You start shivering, you have excessive muscle contraction uses ATP and thermal energy is generated. This is the concept of shivering and exactly muscle contraction. All of the heat loss mechanisms, they decrease temperature. All of the heat gain mechanisms, they increase temperature. Muscle contraction, as I pointed this out in this slide, is exactly what goes wrong with malignant hyperthermia. You have excessive muscle contraction. You have excess use of ATP in these muscles. You have excess generation of heat. It's that easy. It's just the excessive employment of the heat gain mechanisms that causes that malignant hyperthermia. That simple. Okay, so let us look at the concept of excitation-contraction coupling. Why do we need to understand this? Because this will help us understand the excess muscle contraction part and how it relates to malignant hyperthermia and its pathophysiology. This is an example of a muscle cell. So what happens is, normally a depolarization potential arrives. What is a depolarization potential? Normally the inside of your muscle cell is negative as compared to the outside, which is more positive. So a nerve carries a depolarization potential. What is a depolarization? It just means charges moving in, and particularly positive charges moving in. So a depolarization potential arrives, and with the help of this T-tubule, you don't need to go into this detail, with the help of this place, this depolarization potential attaches to this bottle. What is this bottle? This bottle is the sarcoplasmic reticulum. And what does this bottle contain? This bottle contains calcium. This bottle is filled with calcium. So this depolarization potential arrives through this T-tubule. What is T-tubule? It's just the invagination. Invagination means this is like, if this is the wall, and the wall like invaginates inwards to be closer to this bottle, that's exactly a T-tubule. That's the concept of a T-tubule. So this T-tubule causes depolarization potential to directly reach this bottle which contains calcium, which is the sarcoplasmic reticulum. The cap of this bottle is the ryanodine receptor, So basically what happens is a depolarization potential arrives which activates this bottle and the ryanodine receptor, which is its cap. Calcium is released into the sarcoplasm. Sarcoplasm, which means cytoplasm of a muscle cell, it has a very cool own name, which is known as the sarcoplasm. And thus the muscle contraction is initiated. I'm not going to go into more details of how the muscle contraction exactly works, but this is the basic framework. Let's start. The depolarization potential arrives. It goes to that bottle which contains calcium, which is the sarcoplasmic reticulum. The cap of that bottle is a ryanodine receptor, which when opens causes the calcium to be released in the sarcoplasm. It is only when this calcium gets released in the sarcoplasm that muscle contraction is initiated. So what happens in malignant hyperthermia? As I said, muscle contraction is what exactly goes wrong or excessive in malignant hyperthermia. So what goes wrong in malignant hyperthermia? Let's look at it again. Here's another illustration. We have a mutated ryanodine receptor. This cap of the bottle, there's something wrong with this cap. It is releasing too much calcium in the sarcoplasm. It's leaky. This cap is leaky. It causes the release of too much calcium. So whenever that depolarization potential arrives that we talked about here, when depolarization potential, it arrives, it attaches to this sarcoplasmic reticulum, and ryanodine receptor here is leaky and it causes the excess release of calcium. This causes sustained muscle contraction, too much muscle contraction, rigidity. This is triggered by succinylcholine and inhaled gases. So this is my cue to talk about my inhaled anesthetics video. So I have made a very detailed video on inhaled anesthetics, which covers not only the anesthetics themselves, but major concepts like potency and blood gas coefficient, blood solubility, lipid solubility, redistribution, arteriovenous gradient. It talks about all of that. Malignant hyperthermia is triggered by things such as succinylcholine and inhaled gases. Mutated ryanodine receptor, which is the cap of that bottle or the leaky cap of that bottle, causes the release of excess calcium into the sarcoplasm. The sarcoplasm is a cytoplasm of the muscle cell. That excess calcium causes sustained muscle contraction. Sustained muscle contraction leads to increase in CO2, leads to increase in heat. Increase in CO2 causes acidosis. There's this balance. So your blood maintains this sort of a balance, right? The balance that I talked about earlier. So this blood, okay, I hope it doesn't fall. Yeah, so this blood sort of maintains this balance between acids and bases, right? So whenever the acids increase, it sort of tips in favor of acidosis. So your blood has increased acids now due to increase in CO2. Why did CO2 increase? Due to sustained muscle contraction due to that leaky cap. I'm going to keep repeating this until you understand. Acidosis causes rhabdomyolysis, which is just a cool word for saying your muscle breaks down. Rhabdomyolysis, which is such a cool word. Decrease O2. Decrease O2 causes lactic acidosis. Why do we need O2 in our muscles? For oxidative phosphorylation. That's a very difficult word. Oxidative phosphorylation is the normal mechanism in your mitochondria by which ATP is generated. Whenever not enough O2 is present, you move towards another process known as this lactate shuttle. And this lactic acidosis is caused by not enough O2 in your muscle, which is due to sustained muscle contraction. You have too much muscle contraction. Your muscle is not relaxing. You need a constant supply of oxygen and it's producing too much CO2. This leads to lactic acidosis. Lactic acidosis also triggers rhabdomyolysis, which means muscle cell breakdown. So what does rhabdomyolysis cause? Rhabdomyolysis causes the release of myoglobin. What is myoglobin? Myoglobin is something just like a hemoglobin, but hemoglobin has 4 binding sites and myoglobin has 1 for oxygen, right? So rhabdomyolysis, where is myoglobin present though? That's my question for you. Yes, exactly, myoglobin is present in the muscle cell. So whenever you have rhabdomyolysis or breakdown of the muscle cell, you have release of this myoglobin. This myoglobin damages the proximal renal tubule. You have acute tubular necrosis. It also releases purines. What are purines? Your DNA consists of this sugar attached to nitrogenous bases and 3-phosphate stuff. I think so, yeah. So this phosphate stuff, right? So this nitrogenous bases, they come in 2 types, purines and pyrimidines. Rhabdomyolysis causes the release of these purines into the blood. These purines are converted into uric acid. Have you heard that name? I'm sure you have. Uric acid causes urate nephropathy. Those crystals, whenever they get in excess, they deposit in your tubules in the kidney and cause urate nephropathy. So something is going wrong in the kidney. It's affecting the proximal renal tubule by means of the myoglobin, causes acute tubular necrosis. The purines are causing urate nephropathy. Let's clear the pen markings. Yeah. So it releases potassium as well. Potassium causes hyperkalemia. This is very important. I need you to remember this. Myoglobin release causes acute tubular necrosis. Purines cause urate nephropathy. And whenever you have breakdown of cells, remember you have release of potassium, because potassium usually is in higher concentration inside the cell than outside of the cell because of the sodium potassium ATPase channel, which basically keeps a higher potassium inside the cell than outside. So whenever you have breakdown of cells, whenever you have lysis of cells, that's exactly what happens. That's an example of tumor lysis syndrome. When you have breakdown of cells, you have release of excess potassium, which causes hyperkalemia. Clinical manifestations, very important. Severe muscle rigidity. Wow, that's not a surprise. That's exactly what we have been talking about. That's the basic pathophysiology of malignant hyperthermia. Excess muscle contraction, which causes severe muscle rigidity. Masseter muscle spasm. I've added a picture of that. What is the masseter? Masseter is one of the 4 muscles which is involved in mastication. Masseter temporalis. There are 2 more. I don't remember anymore. So masseter muscle spasm, severe rigidity. That's one of the first signs of malignant hyperthermia. Not necessarily present, but usually present. Rhabdomyolysis. What is rhabdomyolysis? It's just a cool word for saying muscle cell breakdown, which leads to increased CK. What is CK? CK is creatine kinase, which is one of the enzymes present in the muscle cell. Where else is CK important? Yes, cardiac enzymes. CKMB is important in the detection of MI. So rhabdomyolysis also causes the release of CK, which is one of the differentials whenever you have increased CK or creatine kinase enzymes in MI, or whenever MI is suspected. High uric acid. We talked about this. Purines. Purines cause increased uric acid. Myoglobinuria. What does myoglobinuria cause? Remember, it causes damage to those proximal renal tubules, causing acute tubular necrosis. This is an example. This picture that I've added here is an example of myoglobinuria. Acute kidney failure. This both of urate nephropathy and myoglobinuria can lead to the presentation of acute kidney failure. How does acute kidney failure present to us? It presents as oliguria, which is less urine. It presents as hematuria, which presents as blood in urine. Severe vomiting. and edema. This is the presentation of acute kidney failure. So malignant hyperthermia can present to us as just acute kidney failure. Let's draw that balance again, the balance that I love, that I love talking about always. Heat gain mechanisms overpower the heat loss mechanisms in hyperthermia, malignant hyperthermia, and hyperthermia is a late sign. The treatment of malignant hyperthermia is very simple actually. Dantrolene. What does dantrolene do? Let's look at that diagram again, and in order for you to revise, to understand, so the depolarization potential arrives, right? So these ions, they try to move inwards. This potential arrives to this bottle that normally contains a lot of calcium, the cap of which is known as the ryanodine receptor, the cap of which whenever is leaky causes the release of excessive calcium. Excessive calcium leads to excessive muscle contraction. So where does dantrolene come in? Dantrolene inhibits that cap. Dantrolene adds another cap to that leaky cap. The leaky ryanodine receptor or the mutated ryanodine receptor, dantrolene inhibits that. Inhibits the ryanodine receptor on the sarcoplasmic reticulum or that bottle that contains calcium. In the end, a summary of all of this. Malignant hyperthermia is a serious life-threatening condition. Malignant, born to be bad. Hyperthermia, increased temperature. It's triggered by inhaled anesthetics and succinylcholine. I have made a video on inhaled anesthetics. I want you to view that. Mutated RYR receptor. It's the mutated bottle on that cap, the mutated ryanodine cap on that sarcoplasmic reticulum bottle which contains calcium. This excess calcium released due to that leaky cap leads to diffuse muscle rigidity and rhabdomyolysis. What is rhabdomyolysis? Just a fancy word for saying muscle cell breakdown. Why does muscle cell breakdown occur though? Muscle cell breakdown occur due to excess CO2, which leads to acidosis, and decrease O2, which also leads to lactic acidosis. Both of these things together cause rhabdomyolysis. We talked about this, remember. It can present, let me clear the pen markings, it can present as acute renal failure. Why can it present as acute renal failure? Because whenever rhabdomyolysis occurs, it causes the release of myoglobin and purines that can cause urate nephropathy. Myoglobin can damage the proximal renal tubule and thus cause acute renal failure, which will present to as oliguria, hematuria, vomiting, edema. And hyperthermia is usually a late presentation. Treatment is dantrolene. Dantrolene, what does dantrolene does? If this was the bottle and this was the mutated RYR or ryanodine receptor, so what dantrolene does is that dantrolene strengthens the cap. It closes off that ryanodine leaky cap. This is our video on malignant hyperthermia. Thank you so much for watching and stay tuned for more videos. Comment in the comment section if you want more topics to be covered. Thank you so much.